So we've been looking at this model through an intensive care type lens, even though it can be applied to acute beds. Acute beds, as we kind of finding more about in terms of the kind of relationship between the demand and the capacity, is probably not as much of an issue for COVID-19 as intensive care. That seems to be where the demand massively outstrips available supply. So whilst a lot of the kind of workings and this model can equally be applied to acute bed base, we've chosen intensive care to look at with it. So maybe some of you might have seen a tweet we put out a couple of weeks ago, and this was the original model, which was quite simple. What this did was basically take as an input the expected hospitalizations, admissions to either acute or ICU over time in the form of a CSV file, just containing a simple 2-column table with dates, so they're containing 7th of March, 8th of March, and so on, and the number of hospitalizations, so in terms of the unfettered demand for an acute or an ICU bed. And all that would then was then required additional to that is some information on the length of stay. And because this original model, as the later model, is stochastic, we're not using averages, we're looking at distributions. So a way to calibrate a 2-parameter distribution, such as a log normal or a gamma, which are typical choices for measuring the distribution of patient length of stay. Given only 2 parameters, we need 2 quantiles. We can match those and calibrate the distribution. So the user inputs then are the median length of stay and the 95th quantile. So basically the number such that only 1 in 20 patients would be expected to stay longer than that value. So again, this can be calibrated based on the acute bed base, in which case in the table above, entering the acute demand and the acute expected length of stay. Now, just a word on the top table. There's been a number of different projections where you would get this demand from. There's been the Imperial report, which I know a lot of healthcare systems have calibrated or interpreted that locally, and that gives you the hospitalisation and intensive care demand over each day. But I believe PHE and NHS England have also been looking at producing forecasts for bed demand by day. So essentially what this simple model did was take those 2 inputs and produce a projection of the required capacity to meet that demand. Okay, so that was just to meet that demand. So you can see here the lower graph there was the output, and that is the bed requirement, showing a longer tail because of the variability coming through the length of stay starting to show. And it also provides obviously the number of beds required at each on each day. Now, the reason why we took this a step further was because we know that on the back of that Imperial College report that everyone's been using, that came out on, I think it was the 16th of March, some of those numbers are rather large in terms of the demand that comes out of that, and we know that our capacity is in intensive care at least is not by and large would meet that. So the next step was to build in the capacity constraint, and the rest of these slides and the code, the latest code, are on that basis really. So building in the capacity constraint requires us to think about what happens if capacity or demand for an intensive care bed cannot be met. So this slide shows the difference between capacity dependent and independent deaths. So we've got, I don't know whether you can see my mouse here. I'll try and point to the bits I'm talking through. We'll have a demand here for COVID-19 presentations requiring intensive care by day. They will be requiring a bed. We have a fixed number of beds. If they do get a bed, then they will be discharged from intensive care, or they will die within intensive care if they cannot be treated if they succumb to the illness. On the other side here, then, if there is no bed available, then the admission is then rejected, and the patient survives in the intensive care example with a very low probability, i.e. if they don't get the ventilated bed that they need in intensive care, evidence shows that there is not such a great chance for survival. And the more likely option is the patient would die if they cannot get that care, that level of care. And this is the capacity dependent death we're talking about here, whereas we can see the death within hospital is the capacity independent death. So this is more appreciated in early case fatality rates, so the case fatality rates that came out of China and Italy. And it's appreciated in these because there is, at the time of these early data becoming available, the peak hadn't been reached yet, so there was no constraint really on the capacity in terms of services were not being overwhelmed. So these CFRs mainly were probably, I would say, the greater part of them was the naturally occurring deaths that would occur within hospital with access to the appropriate level of care. Without any treatment, effective treatment, there's not much that can be done about these deaths, apart from making sure that people can get the bed that they need. On the other hand, for the capacity dependent deaths over here, this is a function of the available bed base, amongst some other things, of course, the demand, the length of stay as well. But there is, with effective planning at kind of government level and local healthcare level in terms of the bed base and so on, there is something that we can actually do to affect these. So the scope of this modelling then is around this. So we're basically assuming to the right hand side of that intensive care bed base flow that patients will be either discharged or will die within intensive care, and we're not measuring those deaths. We're interested in the deaths here that result as a lack of available capacity in the intensive care setting. So we applied this model. We've applied it to actually many of our hospitals in our area. In fact, all of our hospitals in our area. This particular example alone is illustrated using one of those hospitals, which, as I say, it's a large hospital. And on the left-hand side there, these are basically the inputs. So we need to know the demand, how many people are demanding intensive care admission per day. And we've locally interpreted, as I think a lot of us have, the results from the Imperial College report according to the different strategies. So no social isolation, home quarantine and social distancing for over 70s, and the isolation strategy, which assumes those take place, in which case we can expect a lot fewer intensive care demand. The middle graph then is the length of stay, and we've got this from a recent study of a couple of weeks ago, indicating around an 8-day mean length of stay in intensive care. And the third real input then is the capacity. So for this hospital, they originally were able to take on 45 or make available 45 intensive care beds after closing elective cardiac surgery. The first surge then could be to increase that to 76 beds and a second surge to 100 beds. And now actually they're looking at around 200 beds. So the aim then is just...
Sorry to interrupt. Can you just minimise that meeting now window? I hope this doesn't break anything, but it's been covering up some of the slides. So
sure.
Thank you very much.
There we go. So the aim then, in terms of the use of the model in this context, is to assess the impact on deaths from changing, varying or flattening the demand curve, varying the capacity, i.e. the bed numbers through different surge levels, and looking at the effect, how length of stay can be affected, can be changed through various other options in the clinical sense there. And what is of interest then is the responsiveness of the capacity dependent deaths to changes in these handles that we have some control over. So the scenarios analysed then as part of this illustrative example here, we've looked at 7 scenarios. The strategy here relates to the public health intervention in terms of the effect on demand, so whether no isolation, whether the isolation measures I mentioned just then are affected, and if we can further flatten those isolation measures in terms of flattening that demand curve. And for those, we look at various levels of capacity in terms of intensive care beds and the length of stay in intensive care. So the outputs then, these are the outputs from the R function through the stochastic simulation model that we've got embedded in that function. So the first row of results there, there's 3 columns here. The first column is the intensive care beds occupied. The second column is the capacity dependent deaths per day. And then on the third column, it's the cumulative capacity dependent deaths over time, according to those scenarios. What we can see is if we assume that there was no lockdown put in place, then we could see we would end up with a very high number of all of these numbers are quite high, but relatively speaking, number of capacity dependent deaths as a result of people who cannot get their intensive care bed sought. We can see that if we actually put in place as we have now, the lockdown, then this reduces those capacity dependent deaths. So we're looking at the first to the second row, the difference on the third column there, and that through increasing the bed numbers through 76 and 100 through those surge capacities, we can further reduce the capacity dependent deaths there, as would be expected really. Increase capacity and we ensure most demand is met, and therefore more people survive. We can also look at it's the magnitude though of these changes that is really playing through the model here. We can look at how different clinical interventions within intensive care, if they are effective in reducing length of stay, what effect that would have in terms of the capacity dependent deaths, and also look at, as I say, these further flattening of the curve. And through these, you can see the different effects that this has on the intensive care bed occupied beds over time, and those deaths per day and the cumulative deaths. And if we were able to put in place all of those interventions, we can see how that results in the lowest amount of capacity dependent deaths. It's actually about a 5-fold reduction. So that's increasing bed numbers to about 100, flattening the curve, and reducing length of stay by 1/4. And this just shows some of those results here that can be output through the script. And these three columns align to the 3 columns in the plots of the previous slide. But basically, the first column is to understand the effect for workforce planning in terms of how many days are we going to be concurrently at full occupancy. For mortuary planning, it might be has been, at least for us, of interest in terms of understanding the peak daily deaths, and as really an ultimate marker of the efficacy of whatever intervention we're simulating and playing through, is the total number of deaths, and as I say, capacity dependent deaths over the course of the epidemic. Finally then, this is an interesting output. Again, all of this can be got through the tool, and I'll talk this through in a minute. But this is, if we take off the capacity constraint, then this just shows the occupied beds, as I say, without that constraint, and this will give an idea for the various beds that would be required to meet demand at every stage of the epidemic, if all demand was to be met. So if we had around 500 intensive care beds at this particular hospital, then there would be no capacity dependent deaths. Everyone would get the intensive care bed that they needed, even at the peak of demand. I'll just quickly mention some further work. What we're looking at now is augmenting this model that we've got in terms of being able to look at the effect of different admission criteria into intensive care. So to do this, we can set up the arrival of, well, basically, rather than treating everyone quite similarly, is set up patient groups where we can mark those groups based on different age and comorbidity kind of conditions, and then look at rationing intensive care, admission to intensive care based on the effect of age and comorbidities through which patient groups we allow through and within the model. So this is the kind of next steps, and this will be really useful in terms of, and this is what we're hearing from the clinicians in terms of understanding the effect on total deaths, capacity dependent and independent, through different rationing policies. So the R function then, so basically it's just a very simple function here, which takes in how many arguments is that, about 4 or 5. Basically there's 3 main inputs to this. As before, the expected admission, such as a table of daily demand, whether this is acute or ICU demand, the length of stay, again, whether it's acute or ICU, and then the capacity constraint in terms of the number of beds and what happens if a bed cannot be found for a patient that needs it. And this is through the PFAT, which is probability of fatality, patient death, if they cannot access the bed. So for acute, this might be quite a bit lower than intensive care, if we're assuming care would otherwise take place in the community. And this just plays through some of the examples we can do. So we can look to increase bed capacity and play through the effects of that, and look to flatten the curve over a greater window of time, and the effect of that in terms of those performance measures. Right, so that's the kind of summary really of what the tool is doing. So the script itself, I'll just see if I can bring this up. So basically, this is all on GitHub, and these are the inputs essentially here. So there's, well, first of all, I'll say these are that's the main script there. So if I load that up here. It's got those arguments that we just went through, cases, here the capacity and the probability of death if bed cannot be found, and implemented that through basically a function call here, which runs through the various different arguments and the options aligned to those scenarios. So the inputs then are as simple as, well, this would be the do nothing one. So this is if there's no social isolation measures put in place. So we just have the dates and the hospitalizations, and perhaps I can just show you here what that would look like. And then we can look at, we can input, again, all of these being derived from whichever epidemic curve you're running from, whether it's the Imperial College one or the PHE or NHS one. This would be our best guess that we're using based on the Imperial report. So here, this basically just feeds in that curve for ICU requirement for this particular hospital. So that's one of the inputs, and as you'll see from the function up here, I've read in each of those 3 ones there. So the do nothing, the current isolation strategy, and then the flattening, the further flattening that mentioned in the slides. And then essentially then whenever we call up the function, we just input for cases, which is the argument, whether it's the do nothing, the current strategy, i.e. the isolation, the lockdown one, and then the parameters for the length of stay, which in this case, using the gamma distribution, are alpha and beta. And these have been taken from a study in the published literature, which has investigated this recently in the UK setting. And also we enter in the capacity. So in this scenario here, so this is the baseline one, we enter in those 45 beds up to the 76th first surge and 100 second surge, and the probability of death 99%. We're assuming basically if you need an intensive care bed, you stand a very, very low probability of surviving if you're not able to get one, but we can vary that based on the emerging literature as well. The number of replications then, because this is a stochastic model, we don't want to incur simulation error, and simulation error occurs when there's too few replications performed. So really you want to set this to be the largest that you can run through in the time that you've got in order before getting, before you want to get the results. So if I just load some of these through here, and I'll just set 10 replications here, and if we do this one here, so scenario 4, if I just run that, we should see here all of the cores start to work. The code is parallelized, so it sends each of those replications and queues them up on each of the cores that are available on the computer. So we can see those working there. And that will just run the function with those arguments in, and it will place the results back in the working directory. So fine, it's done that now. So that's scenario 4. So we'll look in the working directory here for scenario 4, and we can see here the time shows that as well, 13:54. So it's these results. And so these are results that it has output. So if I just load up one of the graphical outputs, this basically shows the results that have been that were in the slides. Basically a similar thing. This is just actually charting the inputs that are fed into this. This is then an output in terms of the occupied beds over time, according to that level of demand, the length of stay, and the available capacity. So if you recall in here for scenario 4, we'd increase capacity to 100. So we'd put capacity equals 100 in there. And we can see that there in that middle top graph where we've got the dashed line at 100. And as you see here, as the demand is met in terms of beds that become more and more occupied, when it hits that limit, then we start to see the capacity dependent deaths start to increase there, and consequently that when the occupied when there is available capacity in the ward, we start to see them come down as demand is then met for the later stages of the epidemic curve. The confidence bands are put on by, as I say, this is a stochastic model, so the different replications provide each one of those replications provides one possible or describes one possible way in which events could pan out over the course of the time considered here in the simulation. So we're able to then, through those different replications, the different results of those, form a distribution of outputs at the various different performance measures at the various different times on the x-axis there, and that gives us then these confidence bands here on the outputs. I think probably that's everything really. I mean, all of this is up on GitHub. As I say, you can. It just takes these very simple arguments here into the function, and then it's just a matter of calling up the function really, and the results and the outputs should come from there. The output, the CSVs, there's cumulative measures and just the raw per day measures, and these are, you can reconstruct the figures from these outputs actually. This is the table of information that is used to construct those figures, but it provides all of the various fields in terms of the different quantiles on the numbers admitted, the occupied beds, and so on. So if we wanted to look at the occupied mean beds over time, I think we can probably just plot this here. And this will give the curve that you've seen then also in here, basically. So the curve here, the mean of that is the same as what you're seeing here, and then you can get the various other quantiles and plot them which is essentially all of the function that plots this is doing. So I think that's probably where I was going to end it really. So just to say, on GitHub, provided are these these scripts, and some of the inputs we've used that of course you can vary however as required, as well as some other bits and bobs, but these are the main things here. Right, Tom, that's where I was going to leave it for now, I think.
Excellent. That's really great work. We've got a lot of great questions coming through, so I'm just going to quickly share my screen, but feel free to take over it again, Richard, if you want to kind of flick any more code examples up. I mean, thanks so much for the code. I'll start with that one. A nice, easy one, but yeah, I think it's really great code. As you mentioned, it's on GitHub, so anyone that hasn't spotted the GitHub link so far, I think if you look on the NHS Twitter feed, we'll make sure it's certainly shared there later, along with this recording. This first question here, someone went through the code and you mentioned the LOS mean, but you're using the median. What led to the decision to start using the median instead of the mean? Was it skew?
Well, ultimately, the model is taking in a distribution, so it's taking in the whole distribution. So it's whether we calibrate that distribution using a mean or a median, as long as those are aligned from the data, it should give the same distribution that is then fed into the model. So the mean is, we use the gamma distribution. Originally, I think in the code we put up, it was the log normal, but then based on a study by DC and others recently published, I think it was it's in the paper that's up there. They found a gamma distribution was best, with alpha equals 8 and beta equals 1, and alpha in a gamma distribution is the mean. In terms of the outputs, I believe we are plotting the median as well as the other quantiles, and it's just down to preference really, I suppose, what is of interest in terms of plotting. I mean, for any right skewed distribution, the mean is always going to be greater than the median. So that skew, as is mentioned in this question, will play through there. I think that that's probably as much as I can say on that, really.
Okay, that's answered that question quite well. Thank you very much. Hopefully we sorted that one out. I think you'll have to bear with us as we're all trying to learn working from home and presenting stuff remotely. There's technical challenges that we're having to read, so hopefully we fix that. Scan through the code, looks really good. Thanks for sharing. Is there any way to test your model with retrospective data, such as data from some region in Italy, for example? And I think that probably ties in as well with this question. How are the models doing compared to real numbers at the hospital? If you'd like to try and answer those. Oh
yes, no, that's an interesting one. I guess, I mean, the outputs of the model are the occupancies, are the deaths that would occur as a result of not of the demand not being met. I mean, that in terms of the second one there, in terms of the capacity dependent deaths, that's really, the treatment of that in the model is fairly trivial, just through the probability that is put in as one of the function arguments. I think that's probably just something that just needs to be updated over time when we get more information. In terms of occupancy levels, it's a very good point. How do we actually validate this? There's going to be lots of moving parts in what's going on the ground, and the extent to which we are appreciating the most important of those will play through when comparing what the model is projecting against what is actually happening, and that will give us an idea of do we need to increase the level of sophistication in the model if there's something we're missing out. But no, that's a very good point, and I think we'll have to have a look at the outputs of this and how this compares. I think probably it's fair to say that the model itself, as long as it appears, and it's not really that complicated, as long as that the construct of the model is sensible and logical and so on, the greatest, I think, differences in what could come out of it compared to what's happening on the ground would be through the accuracy of the inputs, many of which are just projections and are changing day by day. So, for instance, the Imperial College report that I alluded to in terms of what has fed our demand, our ICU demand by day, is, you know, the authors of that a week ago said, oh, well, actually, you know, the peak deaths that we could, worst case, instead of that 500,000 that was talked about from that 16th of March, the original report, is now, I think, you know, around 7 to 20,000, perhaps around there as an estimate. So that would have then obviously ramifications on the numbers that we're feeding in. There's all sorts of different epidemic curves out there, and at the moment, you know, there's so much inaccuracy inherent in them. I imagine that would affect this. So it'd be a matter of comparing the outputs against also the actual demand that is coming into the model as well, and validating essentially what is an input to the model as well as the model outputs, if that makes sense.
No, that's great, thank you. So this next question, I ran your code and it's quite time intense when we increase the number of repetitions. Any plans to transform your big function into a package and maybe divide it into small functions inside this package?
Yeah, that would definitely be something I imagine would be quite helpful to do. We're not planning that at the moment. I think we're mainly looking now around, as I say, around extending this model to appreciate the admission criteria and the various what if scenarios that we can do around that. I have noticed this actually because on our work desktops we've got 36 core processors on it, so they crunch through this quite quickly. But on my smaller laptop, it does seem to take some time. I think what would probably be quite helpful in the interim is if we could do a bit of benchmarking in terms of the lowest number of replications that can be got away with in reducing the vast majority of simulation error. So if I can have a look at that and suggest perhaps a sensible level of replications that is needed.
That's great. I think it's always the trouble when you increase the number of repetitions, it's inherently increasing the computation time, and simulations can start eating up your CPU usage. Certainly not jealous at all of your 36 core machines. So next question, how much do the predictions vary if you choose a different infection curve?
Well, lots. So this it goes back to the question before, I think, and this is a key what's the word I'm looking for? Dependency of the model and dependency of the quality and accuracy of the outputs. It's all tied down to that crucial input of what is the epidemic curve. So it varies an awful lot. So I would suggest if you're using this model, as we're doing, when we look to a new epidemic curve in terms of one that we think is more accurate or sensitive to our population or whatever, then we would update and rerun the model with that. And yes, absolutely, you can see some big differences play through based on changing that.
Great, thank you. So we've got probably about 20 minutes left of the time that we booked out. So if you've got any more questions, please remember to just log into menti.com and enter this code up here, 478200. We'll try and get through as many of the questions as we can. Just to note as well, at the end of this, I'm going to flick over to the next page, of this, and there's just some session feedback just to let us know how you thought this went. That'd be really helpful if you could fill that in at the end of this. But, the next question then, why are you using time plus 1/3 of time? Is that because that's the longest you are more or less confident for the forecast, or is it stemming from somewhere else?
Yeah, so that's basically just to, and there's probably a better way of doing this, but we found this typically works. That's just to let the system drain, essentially. So in the epidemic curve, let's say that ends after, let's say, at time equals 100. What we would then possibly find is that by time equals 100, all of the patients who have been admitted have not yet drained, let's say, have not yet been discharged, and the occupancy has not therefore come down to 0, i.e. all of the results haven't played through. So adding the 1/3 is just a way to basically allow the system to drain and for us to capture the behaviour of that. There probably is a much better way of doing this, but that seemed to capture most of the events. Clearly, if you actually put in huge lengths of stay, then that 1/3 of time, let's say if you put in huge lengths of stay and the epidemic curve was over a very short period of time, then the epidemic curve duration plus 1/3 of it is probably not sufficient to see all of that drain occur.
Thank you very much. Next question is, could this model be applied to national level information? So this is pertaining at the moment to one individual trust, isn't it? So how does it relate to national level information?
Yeah, that would be really, we've looked at doing that, but not quite done it yet. So what we're looking to do with this, rather than trying to put in the epidemic curves for the whole country, which, as you can imagine, with a discrete event simulation model, which is what this is under the bonnet, all of that demand playing through and all of the beds being used and discharged and so on would take absolutely forever. It goes back to the previous question about the runtime. The more demand you will be putting in, the more events are happening, discrete events are happening, the more we are running over that big loop, which is just simulating those events. So what we've done is try to think about, could we apply this on a representative 100 per 100,000 basis? So basically looking at ONS population demographics and then rescaling the Imperial College projections based on that per 100,000 representative kind of cohort population, and then playing that through again, putting in then an England average or UK average intensive care beds per 100,000. So that's probably the best way to do it at national level, I would have thought.
Great, thank you. I think there is already work by NHS England looking at kind of the national level stuff, which if anyone joined the Future NHS England webinar on Friday, they were talking about they were struggling to scale theirs down to a smaller level. So there's perhaps the synergy of your model and their work for the different kind of ends of the question, would you say?
Yeah, I haven't had time to look at the NHSE model. I don't know whether it's stochastic or whether it uses average bed numbers. I don't know how aligned otherwise the assumptions are, but it'd clearly be good if there are other models out there which are doing a similar thing in terms of trying to satisfy a particular aim or objective using similar inputs, then how the outputs would differ between those models based on what's going on in that middle bit.
Brilliant, thank you. So the next question we've got here, did you consider any epidemiological models, SIR, etc.? So yes, I don't know about anyone else in this call, but I've certainly learned a lot about new models just by seeing everyone talk about SIR curves and things like that in the last couple of weeks. So
yes, yeah. So I mean, SIR models kind of susceptible in infected recovered, or SEIR, which I think are being used for COVID. They're really the bit that the output of that is the input to this in a way. So those SIR models, which is basically what is systems of ordinary differential equations that exist behind the Imperial College model and some other models that we've been looking at with academic partners in our region. But the output to them would be number of cases, number of cases requiring hospitalization, requiring ICU, and so on, based on the various rates that are played into those models. So that really provides, those models provide the output that then is input into this model. So didn't try to conflate the two here. We're trying to run this in a modular way in our system, where we've got a model, or at the moment it's quite a fairly simple spreadsheet, which turns the Imperial College report projections and interprets them locally, and that implicitly is using the SIR models, I guess, of the Imperial College report, but it's very simple in terms of how we're kind of scaling it down to our level. But we are also talking to University of Bristol around some SIR modelling that could improve that module, that then feeds this module, which is around the bed models and capacity and so on.
Great, thank you. So sorry if I missed this, but where has the capacity dependent death probability come from?
So our ICU consultants have basically said that if a patient is in need of intensive care, organ support, ventilation, invasive ventilation, then if they do not receive that, then they stand a very, very small chance of surviving. Now, even if they are admitted to ICU, they then may also not recover as well. That, though, is out of scope of this modelling. That would be the capacity independent deaths that I spoke to about at the beginning of the slides. So in terms of that probability that we've got there of 99%, that's come from clinical opinion. Now, if we're using this model to look at the acute bed base and looking to, maybe further into this epidemic, if our acute beds come under real strain, and we may have to then think about, patients being cared for in the community and not being admitted, then we could play through, we could use this model in that context. And I imagine in that case, the probability of death, if an acute bed cannot be found, is going to be less than in the intensive care setting. But we've not actually ironed out a kind of a specific probability for that example yet.
Great, and I think possibly it ties into this question if I jump across a little bit. It sounds like the 99% fatality rate is just an arbitrary decision. Is that correct?
Yeah, it's. I think that's the same question and probably the same answer, really.
Brilliant, thanks. Okay, so how did you derive the epidemiological curves from the Imperial work?
Yeah, so I mean, so in the Imperial paper, I believe it's the first table. They provide age-graded rates for cases requiring becoming symptomatic, requiring hospitalization, requiring ICU. So then it's possible to take through knowledge of your healthcare system's population, is to basically bin that population into those age grades, 0 to 9, 10 to 19, and so on to 80 plus, and then play through those various rates, and then you can come up with an age graded list of total ICU demand that you can then aggregate across those age bands to give you your total ICU demand over the course of the epidemic. And then there's also some more information. I think there's a figure later on in that Imperial report which gives the profile over time of how that demand would pan out. So we've just taken it in those two steps, really. First of all, looking at the which I think other systems are doing, and I think there was a Sheffield model that did exactly this as well, that others have been using. But essentially, yeah, just play through those rates and then profile them out based on the curves later in that paper. It is worth saying, though, that and someone tweeted this the other day, that, and I've seen it locally as well in our hospitals, that those rates that were in that early Imperial College report, they gave I believe 80% of cases requiring hospitalisation for 80-plus-year-olds would require intensive care. I think it was something along those lines. Anyway, basically, we're not seeing that come through in the UK at the moment. The number of elderly people admitted to intensive care seems to be a lot lower than in the Italy and China data that was behind the Imperial College report. So just a bit of a warning around that.
Great, thanks. So your peak looks quite late. Have you used a reduce R0 from the beginning, or high R0 originally reducing to lower right up upon lockdown?
Okay, so the R0 being the basic reproduction rate then, so how many secondary cases per one primary case per infected individual. All of that's basically in the Imperial College report, and this goes back to the kind of modular structure of how this model would be arranged compared to the SIR type models. So the way we're seeing it is that the SIR type models would encompass the R0 and the various other rates that would determine projections of the number of cases and thus number of cases requiring hospitalisation and ICU. That is then the output of that is the input into the model been talking about today in terms of those demand figures.
Right, thanks. So the next question looks around the kind of assumptions on the discrete event simulation. There's no warm-up period or pre-priming, so that's an assumption that all of the beds are empty at the beginning of the model.
Yep, that is right. All of the beds are empty and all of them are available for COVID-19 admissions are the assumptions here. I mean, clearly on the second of those points, rather than just using total number of intensive care beds, should probably be putting into the model the total intensive care beds available to COVID patients. Now, as time passes, even with lockdown and reduced kind of traffic accidents and work injuries or whatever, you should imagine that the non-elective demand for intensive care might reduce. Certainly elective demand is reducing through stopping elective cardiac operations and so on. So that can be factored into the available bed base that is input as one of the arguments available for COVID-19. But certainly in terms of the initial conditions, it started empty, so there is no need for a warm-up period. And we are assuming that whenever it started from, all of those beds are available for the new demand.
Great, thanks. So the next question is, what did you get your admission estimates from? Is that from your own local data or from some of the papers?
So admission estimates, I think this is referring to the demand curves, the epidemic curves in terms of the daily demand for intensive care beds. That's through the Imperial College report, or whatever epidemic curve you're using in order to get that profile of demand for beds over time.
Great, thank you. So we've covered this question already, I think. With the impact of the curves, is it possible to run multiple models and identify the most effective interventions on average? Would you expect this to be the same as the most effective for a single curve?
With the impact of the curves, the most effective intervals. I'm not sure. We've not done this. We've run the interventions that alluded to in the slides. I don't think we've looked this far. We've only looked at about 3 different curves feeding into this, at least for this hospital. Looked at other curves for our system as well. I think it'd be best just to play around and see what comes out, really.
Okay, thanks, great. Presume some care is need around the interval around scenario bed outputs, as assuming expected hospitalizations are deterministic, and actually there is some uncertainty around those estimates as well to account for. Could do upper and lower. So any comments on that?
Yeah, so I mean that's exactly right. It's the expected hospitalizations are they are deterministic. There is a parameter that we put into this model called TOL, which is a tolerance parameter around assuming some uncertainty around that demand curve that's fed in. So you remember the table where it's just those 2 columns, the dates and the hospitalizations. If TOL is set at 0, then it assumes that exactly those number of well, according to some Poisson variation, those numbers would occur. But there is a tolerance parameter which you can flex in order to apply some uncertainty around that demand curve, because yeah, absolutely, there's so much uncertainty around that demand curve, especially at the early stages of an epidemic like this.
Great, thanks. So we've just got a few more questions. I think we'll have just enough time to get through these, but through these quickly. Is it possible to aggregate geolocalization of possible cases to, I think that's meant to be estimate demand?
Is it possible to aggregate possible? I'm not sure I quite understand that question. If it's around of possible cases, so is this unconfirmed COVID cases to estimate demand? I think probably this would have to be fed in or dealt with in that in whatever model or approach is used to determine the demand feeding in.
Great, thanks. So replications, possible methods is confidence interval methods is a possibility to see page 154 simulation, the practice of model development and use Robinson. So more comment really that a way that you could improve your model.
Possible methods.
So hopefully that's of use to you. Great. Please could you share the simple scaling Excel model? So if that was in your GitHub profile, I think it's already available.
Yeah, so I think the I think this is around the demand in terms. I think this question is around how the Imperial College stuff is scaled locally. I'm not sure we've got a version of that, because I say it's a kind of separate module as we see it. The outputs of that feeding into the inputs of this. I don't think we've got that in I'm not sure what position that is in terms of making that available, but essentially it's really not that different to what Sheffield have done. So I think some of us might be aware of a Sheffield model interpreting that Imperial College report that has been doing the rounds. I think it's up on the Future NHS site as well. So I'd probably refer to that because I think that's doing pretty much exactly the same thing. As long as the outputs of that can be put in just a simple 2-column table in terms of the dates and the number of cases requiring hospitalisation, then that's all that's needed for this model. I believe we are though waiting on NHS and possibly PHE as well jointly to put together a case projections and hospitalisation projection model that I believe is meant to be coming out quite soon. So if that comes out and that has better curves with more useful, relevant data feeding that, then what we'll be doing first, as soon as we get that, is repointing this model at those updated curves.
Great, thanks. So this next question here, are you looking at O positive and V beds instead of just overall ICU beds? Now, I think this is to do with the kind of oxygen support level around the beds. Because I think that's what NHS England's model has called their thing. So hopefully that makes sense.
Yeah, the comparability to it. Yeah, we haven't to date, not kind of explicitly, at least implicitly. I think the kind of assumptions around mechanical ventilation would only be able to happen in intensive care beds. I mean, the model itself can be used to, in the same way as looking at beds, look at resources such as ventilators. So if we were to have a length of stay for how the distribution of time patients required a ventilator, the demand for ventilators and so on, the model could be just as easily pointed at that, and then it would be tracking the occupancy in terms of the ventilator utilization and so on over time.
Great, thanks. So this is a comment, this next one. We use the age-specific estimates in the epidemic model to give a rough idea of what it would look like if we didn't admit over 80s to ITU as a proxy for not suitable for escalation. I know that's crude. It was a massive reduction, about half. So
yeah, Yeah, and that would be probably just through that first module in terms of how you work up the demand for intensive care, and I'm guessing that would be just a matter of taking out that last age band, and assuming that that demand is not going to be met by intensive care. So just removing that before you aggregate, and then split it over time. Yeah.
Great. So we're pretty much out of time on this. So I think it'll probably be best to end it there rather than take up any more of Richard's precious time. So sorry we didn't get to answer these last few questions. But if you wouldn't mind, we've got this review of session just to kind of go through our Mentimeter. So I think this has been set so you can go through at your own pace, just on this code up here. And that'd be really helpful for that feedback on there. We'll make sure that on the NHS Twitter feed, we share the link to Richard's team's work on GitHub. So if you haven't already seen it, it's really impressive work. And just to say thanks, hopefully this has been really helpful for you. If you've got any other work that you're doing yourself, feel free to reach out to us on the Slack channel or through the NHS website or Twitter. Because we'll happily host a webinar for you if you've got some interesting work to share, whether it's COVID related or not. But thank you all for your time, and hopefully see you all again soon. And thank you very much to Richard, of course.
Thanks, Tom, for organising as well. Thanks all.